All right. Good evening. Thanks for joining. This is Dr. Jaspreet Singh with Premier Medical Group. Just after 6 o'clock, so value your time. I will get things started. All right. So thanks again for joining series. This concludes our last series. Uh, our last presentation of our series for Movember Men's Health. And this evening's topic, we're going to be talking about BPH or benign prostatic hypertrophy and urinary changes and how the symptoms present and what our treatment options are. Again, for those who don't know me, I am Dr. Jaspreet Singh. I'm a board certified urologist where I did my urologic and general surgery training in Philadelphia, Pennsylvania. I stayed on staff at Thomas Jefferson University Hospital for a few years before moving to the Mid-Hudson Valley. This is where I grew up. I've been with Premier Medical Group for the last 14 years. And if anybody's interested in a more in-depth follow-up or consultation in the office address is listed here. I'm at 955 Little Britain Road in New Windsor, New York. The number to the office is 845-437-5000. And our website is listed here, www.premiermedicalhv.com. All right, so today's agenda, we will be talking about benign prostatic hyperplasia, commonly known as BPH. We will learn about how we go ahead and diagnose BPH and what the treatment options are for BPH. So, of course, as a urologist, I hear this often. These quotations, as you see here, patients are often complaining about getting up at night or having to look for a bathroom urgently. Perhaps takes a long time to empty the bladder where things are weak, it's a slow stream, and often will describe somebody coming into the bathroom after them and leaving before them while they're still struggling to empty the bladder. So let's understand BPH before we review some treatment options and symptoms. And so what is the prostate gland? It's a gland that sits right next to adjacent to the bladder, and it is important in the male reproductive system. It helps produce the fluid needed in transporting sperm during ejaculation. Now, the issue here at hand, as you see, is that the prostate surrounds the urethra near the opening of the bladder. And I think most of us misunderstand that the urinary channel that runs through the prostate is a separate tube, like a straw perhaps that's going through an orange. But that's really not the case. You have the bladder, and then the path that the urine leaves the bladder runs through the prostate. That actually is part of the prostate. There's no separate tube. That prostatic urethra is anatomically part of the prostate. And then, of course, the urethra starts after that. And, the one downside to being a man and aging, and a lot of this is dictated by genetics, is the size of the prostate will grow as a man ages. So these symptoms can start as early as in the mid-40s, but will progressively increase as a man gets older and more apparent in the 60s and 70s. In fact, by the time a man is 70, about 3 out of 4 men will be reporting symptoms consistent with secondary to prostatic enlargement. And so BPH, commonly known as just enlarged prostate, it's a progressive condition, right? So that as one ages, the degree of bothersome symptoms will progress due to the progressive size increase of the prostate, and also the changes that occur within the bladder to help compensate in being able to empty the bladder effectively. Now, what I mean by that is the bladder itself is a muscle known as the detrusor muscle. And so when the bladder is full, it sends a signal to the brain. The brain gives it permission when it's socially acceptable to empty the bladder, and will send a signal to the muscle to contract. And so what happens after years of a bladder outlet obstruction from prostatic enlargement, the bladder has to compensate and undergoes a process where it hypertrophies. It's almost like being at the gym. If you're to do dumbbell curls, your biceps muscle would hypertrophy, and the same thing happens to the bladder. And so as those dynamic changes occur, where the bladder itself thickens, it can undergo changes that will that will store urine. And so men will often report irritative symptoms such as frequency and urgency because the storage component in the bladder has been impacted due to an outlet problem. And so, yes, many of us, as we age, will accept the fact that our urinary pattern is changing, but often these changes within the bladder can be irreversible and sometimes lead to a bladder not being able to function, hence leading to urinary retention from a non-functioning bladder. So, yes, although these are progressive changes and will be more apparent as men get older, but one shouldn't necessarily ignore these symptoms. It's also worthwhile to help illustrate and point out that this entity is a benign process and that BPH is not prostate cancer. But the reason why this is one of the most common reasons we as urologists treat men with is that it impacts the quality of life. And that most of the time, where men can put up with the fact that they are accepting the fact that the stream is weaker, or perhaps not emptying the bladder completely, they'll affecting the urgency or impacting the ability to sleep at night. Men will often seek intervention and talk to their doctors about. And so, on that note, what are the symptoms of BPH? Well, as the prostate enlarges, it can squeeze or press on the urethra, causing obstructive symptoms. And the way to help divide the symptoms of BPH are into two categories. One include what's called obstructive. So the obstructive symptoms can include difficulty or delay in starting urination, or perhaps some hesitancy. Uh, Also symptoms of intermittency, where the stream is stop and start. So it's not a consistent flow or a consistent stream. And of course, a weak or slow stream. All are irritative voiding symptoms or irritative BPH symptoms are typically from frequency or the need to urinate both day and night, waking up at night, having urgency to urinate, um, and sometimes difficulty postponing urination, where men will often have an accident on the way to the bathroom. Often men will describe symptoms where, as they're pulling up into the driveway or they're putting the key into the front door, that urge is so severe and sometimes can lead to incontinence. And so as I was discussing the bladder changes, and often most even treating physicians will concentrate on the prostate or the obstruction aspect of the BPH spectrum of symptoms. If BPH is left untreated, it can worsen lead to permanent bladder damage due to an obstruction. So I've taken out the opportunity to show what the inside of the bladder looks like. Now, this is based on a procedure we typically do as uroscopy, where this is a normal-looking bladder, a healthy bladder, and often looks like the inside of your cheek, nice and smooth. And as prostate enlarges in the bladder, this is the actual hypertrophy of the of these striations, what we call trabeculation, and these will progress over a period of time. These can often lead to pouches within the bladder called diverticulum, And permanent damage is often leads to urinary retention requiring Foley catheterization. So of course we want to intervene early so that we can not only help quality of life symptoms, but also preserve bladder health. All right. So how do we go about diagnosing BPH? Well, we've spent the last 10 minutes talking about urinary symptoms. So this disease process is typically diagnosed based on urinary symptoms. A standardized questionnaire that often will be provided to my patients in the office is something called the International Prostate Symptom Score, or also in the United States known as the AUA Symptom Score, the American Urology Symptom Score. This is a questionnaire, validated questionnaire that includes 7 domains that assess the different aspects or the symptoms of BPH that are categorized into 3 main categories as mild, moderate, or severe, based on the adding of the symptoms here. And each domain is broken down into a score of 0 to 5, where often the answer to a 0 is something that's not experienced at all, to a 5, which is experienced almost always. And so these include incomplete emptying, the need to urinate more frequently or less than every 2 hours, intermittency, where there's a stop and go, experiencing urgency, where it's difficult postponing urination, a weak stream, needing to strain to up at night. Now, of course, many men that I talk to will have urinary changes and may even, in fact, fall into the moderate or severe category, but many patients will um, adjust to these type of changes and may not necessarily share a bothersome quality of life score. And the quality of life score is broken down into again seven numbers, of which 0 is something that a patient is delighted with their urinary symptoms, and of course 6 is scored as terrible. And the question, the quality of life question, is based around if you were to if one was to live like this for the rest of their life, how would you feel about it? You know, from delighted to terrible. And so, of course, I've had patients who will report some changes as far as the stream, it, uh, won't be bothered by it. And so often our treatment plan is revolved around how bothered are any symptoms. In fact, it brings a story to mind where I had a patient, of course, elderly patient who had some BPH and was reporting that he was getting up at night 3 to 4 times to urinate. Now, of course, that seems excessive to me. To me, if I wake up more than once a night, I find that bothersome. So I asked him whether that was annoying, and he turned around to me and said, "Doc, at my age, I'm glad I'm being able to wake up at night." So I guess that's point well taken, where he didn't bother him, or he was retired and fell back asleep pretty quickly. All right, so the screen is popping up here. All right, just bear with me a second here. We got. All right, let's go ahead and share that screen again. Okay, so how do we go ahead and diagnose prostate enlargement or BPH? Well, there are various tests and examinations that we have access to. I think one of the most important things is obviously sitting down with the patient and getting a medical history. And that's where things like questionnaires, including the IPSS, come into play. A physical exam, still very necessary part of assessing prostate health, includes a digital rectal exam. Many of my colleagues who are primary care providers have excluded this as part of their physical exam, but I think this provides a significant amount of information in a quick exam to get an assessment how enlarged the prostate is and any sort of abnormality that's maybe associated with other things like prostate cancer. PSA is usually not used to screen for prostate enlargement. I do have some colleagues of mine that are primary care providers that will. Um, In general, PSA is usually used to screen for prostate cancer, but as prostate enlarges, there will be a rise of PSA level. But men with a significant prostate enlargement may not necessarily demonstrate a PSA elevation, so it's not really a good surrogate marker to screen for prostate enlargement. A urine analysis is a basic part of an examination or an evaluation in the office. A urine sample helps to help exclude other reasons for urinary changes, such as diabetes. Diabetes itself can result in frequency and urgency to urinate. So urine analysis helps to evaluate for any presence of sugar. Also, urinary tract infections may be associated with changes in urinary pattern. So that's a quick test to help evaluate that. And then finally, to exclude any sort of blood that may be in the urine. Um, there is an overlap of a disease process called an overactive bladder, and that in general includes patients who have issues with their bladder, where their bladder cannot store urine, which leads to frequency and urgency. Um, Helping to put together a diary or a volume chart helps me to help navigate between whether this is an issue with an overactive bladder versus a prostate problem. So sometimes patients will be provided a log or a diary to keep track of what they're drinking, and also to measure and to document when they're urinating. It also helps me as a urologist to help differentiate whether the excessive need to urinate at night is truly a problem with the prostate or an issue where the kidneys are just making too much urine, an entity called nocturnal polyuria. And so when we have a differential diagnosis of various reasons why urinary changes can occur, these kind of non-invasive tests help to initiate a treatment algorithm or a process to help patients. I still see countless amount of patients that will come to see me for waking up at night who have been put on prostate enlargement medications. And when I examine them, they don't have an enlargement of the prostate. When we do the diary, it's an issue that is related to perhaps the diuresis that occurs at nighttime in men as they age. So, having again goes to medical history, having a good baseline assessment of urinary pattern is important. Uroflowmetry is a test we do in the office. It's a flow test where patients will come into the office with a full bladder and empty their bladder into a machine that helps us to assess the pattern of the urine and also how good the stream is or with what force is somebody urinating. Often the terms weak stream or doc, I'm urinating with a strong stream is a very subjective assessment. The uroflowmetry helps us to evaluate objectively what the health of the stream is, which can lead to further discussion whether the diagnosis of BPH is accurate or not. Sometimes we have patients undergo ultrasounds of the prostate to help assess how big the prostate is and to understand the anatomy. And sometimes for patients who have issues with PSA elevation may lead to an MRI of the prostate. Uh, some of the other workup we do in the office that may be more involved, especially in patients who may go under initial treatment with medications who are not responding, a procedure called a cystoscopy, which is done in the office. It's a procedure that allows a urologist to take a look inside the urinary channel with a camera. So you get an assessment of the shape and size of the prostate and how its effect has been on the bladder. Also helps us to exclude any sort of other reasons for urinary changes such as bladder tumors, the bladder stones, by taking a quick look inside. It's a fairly painless procedure, albeit it is uncomfortable. It's a sensation like you have to urinate. It's a quick test, takes less than a minute or so to assess appropriately within the bladder and the urinary channels that runs through the prostate. Some of the other testing that you may experience in the office when you come see me are something called a bladder scan or a post-void residual check. This is a quick scan above the bladder. Doesn't really give us anatomy of the prostate or the bladder, but it gives us a quick sense whether somebody's emptying the bladder. Now, of course, one can understand that the frequency of urination can be exacerbated if you're not emptying the bladder. So that as any cup that you only empty halfway, it's going to fill up that much quicker, and hence that's how the bladder would work as well. So the frequency, we want to make sure patients aren't retaining too much urine that may lead to some symptoms of prostate enlargement, such as frequency. There are more in there are more comprehensive testing that typically is reserved for patients who are failing intervention, such as urodynamic study, which allows not only to study the component of obstruction when one's urinating, but also the ability to assess objectively how well the bladder is functioning, how well it's storing, and obviously squeezing and emptying. Because at the end of the day, a weak stream may not necessarily be associated with prostate enlargement. It can also be seen in men who have weakness of the bladder or have some sort of neurologic problem that may increase the risk for weakness of the bladder, such as diabetes or other neurologic conditions such as multiple sclerosis or strokes. So what, the cystoscopy is a quick test, often done while awake. One patient can come in and drive that themselves. It's a thin tube that allows us to evaluate the bladder and the urinary tract, helps us to rule out other bladder conditions. So I think most men obviously would shy away from having a camera put into the urethra, but I have to reassure you that it's a relatively quick exam, and many men tolerate it without an issue. All right, so we've discussed the symptoms and signs and symptoms of prostate enlargement. We've discussed what some of the workup can entail in the urologist office. So let's finish the talk and talking into a spectrum that starts from least invasiveness to most invasiveness. And of course, the least invasive of the options include just watchful waiting. Um, waiting, as we discussed, some patients are not bothered by their urinary symptoms. Their quality of life is not impacted. And so we'll choose to monitor the patients, perhaps see them every 6 months or a year to ensure that their symptoms aren't worsening and that they're effectively emptying their bladder. Medications, we'll get to in a second, and then some of the surgical options that we have. And as we divide again into the invasiveness or classify the invasiveness of the procedures, the least invasive of these procedures is the UroLift system, followed by more invasive procedures such as heat therapy, laser therapy, water jet ablation, and of course, surgery, typically reserved for men with significant prostate enlargement. Medical management, there are two classes of medications that we use to treat prostate enlargement. By far, the first line of intervention is a class of medications called alpha blockers. And there's several medications that fall within this category. And the most common include tamsulosin, alfuzosin, or silodosin. The trade names for these medications are tamsulosin is called Flomax, alfuzosin is uroxetrol, and silodosin is Rapaflo. These medications are often the first line because they're fairly easy to get. They're pretty much all generic. They're, for most men, easy to take as it's taken once a day. And most men will tolerate the medications, although there are side effects, which include low blood pressure, especially when somebody is standing up from a seated position. This is something called orthostatic hypotension. um, this is typically seen when the systolic blood pressure drops when someone stands up. This can lead to lightheadedness and dizziness. And so often these medications are taken in the evening before bedtime. But the most of these medications are 24-hour slow release, that even though you take it at nighttime, the medication is in your system for 24 hours. About 15% of men will experience these side effects. Other side effects include nasal congestion or stuffiness, an entity called retrograde ejaculation. This seems to occur at a higher rate, somewhere about 20 to 30% of men. This is an entity where when a man orgasms, the amount of ejaculate volume decreases, or it's a retrograde ejaculation where it actually goes into the bladder. Not a harmful side effect, but in many men can impact the quality of life as it can affect their sense of sexual satisfaction when the ejaculation is disturbed. Of course, this is a treatable side effect. I'm sorry, not treatable, reversible, so that when you stop the medications, that side effect disappears. Alpha blockers have been on the market for over 30 years, um, and the different generations have just gotten a little bit better with lower side effects, but many men will still complain of side effects. Also, to note that these medications, the alpha blockers, cannot be mixed or taken with medicines used for erectile dysfunction. They should be gapped by at least 4 hours, so this can sometimes be an inconvenience because taking it with medicines like Viagra or Cialis can potentiate low blood pressure. So one has to be careful with that side effect. And and of course, what the studies show, in 12 months after taking any of these medications, about 30% will either stop taking the medication due to side effects or will have progressive symptoms that are not responsive to medication. So that's essentially 1 out of 3 men will fail medical therapy. And many men won't go to the next step to even talk about further surgical options. So a lot of men will often deal with these urinary changes without seeking medications. The other class of medications are called 5-alpha reductase inhibitor. These medications actually will decrease the size of the prostate. These group of medications, the way they work is they help block the conversion of testosterone to a more potent version of testosterone called DHT. And it's ideally specific to the testosterone conversion in the prostate. But as with, many of these medications, their side effects can overlap where men can report changes in libido, diminished sexual desire, erectile dysfunction, and sometimes breast enlargement or tenderness. Now, the way these medications work is by lowering the DHT within the prostate. It lowers the stimulation of prostate cell growth. And so over a period of time, the prostate size will reduce. Now, unfortunately, it's not a magic pill. What the data shows on average, the size reduction is somewhere about 20%. And so, it's again men who may have enlarged prostate, the size reduction may not be adequate enough to help them with their urinary symptoms. And these medications will take at least 9 to 12 months to notice a symptomatic improvement in the symptoms. So these are long-term medications. These are medications that once you stop will then re-stimulate the prostate to regrow. So it's this particular medication, this class of medication would be something that we would give long-term and kind of indefinitely. So a condition that affects men, BPH, may sometimes result in men taking multiple medications. And so where we're trying to treat the disease, there are few conditions as urologists that I can treat with surgery that eliminates the need for medications. I often have this discussion with patients in the office where many of us would agree that if there was some sort of a procedure that would take care of their high blood pressure or diabetes, most men will sign up for that so that they can achieve long-term benefits. And that's where really surgical intervention comes into play, where we can take patients who not only fail medications, but perhaps are having side effects or just don't want to take medications and help them with their urinary symptoms long term. Patients will often ask me about herbal therapy. In general, saw palmetto or beta sitosterol are kind of supplements that are often taken and marketed to men kind of over the counter to help with the urinary symptoms. Both of these medications have been studied in placebo-controlled trials, and unfortunately, they have not demonstrated uh, uh, any clinical scientific data supporting their benefit in urinary symptom control. Now, the reason why some patients will pursue these and often who do continue taking it will swear by them is very interesting because when you look at the clinical trials that approved medicines like tamsulosin or Flomax, in men who received the placebo arm, meaning essentially a sugar pill and not the medication, uh, different trials, about 20 to 30% of men that received placebo reported that their symptoms improved. Now, of course, they were blinded to it. They didn't know that they were getting the medication. So, of course, these urinary changes can wax and wane, and patients, even in those clinical trials that received the placebo, said their symptoms improved. So I don't know whether there's a placebo effect to these medications, but they're not harmful. So men who decide to pursue these therapies, I don't discourage it per se, but I do put into perspective that scientifically it hasn't demonstrated any sort of objective improvement in improving urinary symptoms. As you know, you can understand that, a disease process that affects 70% of men at the age of 70, it's a big market, and there are tons of over-the-counter medications, formulations, beta prostates, and so forth that are marketing and getting men to take these over-the-counter medications. So let's talk about minimally invasive surgical options that we have. The UroLift system is a minimally invasive treatment option that can often get men to get off their BPH medications. It's an outpatient procedure and really takes somewhere about 10 minutes to complete. It avoids any sort of major surgery and also helps preserve sexual function. This is one of the only options that we have that has demonstrated really no sexual side effect, including ejaculation, that it maintains and preserves the ability to ejaculate. It is one of the only leading treatment options that does not require cutting, heating, or destruction of prostatic tissue. Now, how does the UroLift system work? Let's take a look here. I do have an animation in a second here. So this is a kind of an cartoon of what we're doing. So here's a cartoon of the bladder here, the prostate next to the bladder. What we do as an outpatient, and often the procedure is done with mild sedation, very similar to colonoscopy sedation. It allows me to insert an instrument into the urethra, get to the area where that prostate has enlarged and it's squeezing the urinary channel. And what we're doing is we're lifting up the prostate. Almost imagine we're lifting curtains that are drawn closed, and we're opening them up with drawstring. So we're able to push or re-lift that prostate tissue, and we can anchor it in place and hold it in place by putting in this UroLift implant. And essentially what it entails is a anchor tab that sits on the outside of the prostate, a suture material that essentially is a drawstring, and it cinches and pulls together what's called a urethral tab or a urethral end piece, which is now lifting up that prostate and keeping under tension. And in this fashion, when the prostate is lifted, it opens up that urinary channel, allowing the restoration of a nice open channel and an unobstructed urethra. The nice thing about these implants are that they're inert. There is no contraindication in getting select MRIs. As long as you make aware of the imaging center, there's no contraindication in getting MRIs. They don't beep at a metal detector. And the usage of clips are very common in surgery. There's a very similar material that we use when we, remove a gallbladder or appendix. These clips are often used to safely, remove those organs. A similar kind of a concept. These are inert. They don't cause any issues. They're not felt once they're inside the urinary channel. And so this is something that's not a new procedure. I, in fact, was the first urologist in the Hudson Valley that introduced this community to a UroLift procedure back in 2014. So I've been doing it for over close to 10 years. In the United States, there have been over 500,000 men who have been treated with the UroLift procedure, and there are many publications supporting the long-term improvement of urinary symptoms after men undergo this procedure as well. So the side effect profile compared to what's considered, quote unquote, and that's up for controversy, the TURP procedure or the transurethral resection of prostate, a better risk profile, better recovery, quicker recovery to normal day-to-day activities, and something that does not affect sexual function. So most men will need a catheter overnight that's easily removed by the patient in the office or at home. And the healing part of that procedure is more of an irritation, where, of course, when we are putting these implants in, the prostate will swell up. And it takes about a week and a half for that swelling to settle down. And as that prostate swells, those symptoms can include some frequency and urgency and mild discomfort and urination. And each day gets better after the procedure. This is the animation here. Let's see if this will work. All right, we'll fast forward a little bit here. Okay, so here's the anatomy here, bladder, prostate, the urinary channel. So we're inserting the camera into the urethra, and we can see the obstructive part of that prostate. You can appreciate the mechanism of action. So this is the UroLift device. We're lifting up that prostate and then essentially anchoring it into place by deploying this implant that will send the anchoring tab on the outside of the prostate. And then this is where surgeon experience is needed, where we're able to tension and apply the appropriate tension that's needed to lift the prostate, and then place the urethral end piece here to keep that prostate lifted. And we repeat this process. Each size of the prostate dictates how many implants we put in. So on average, we're putting in about 4 to 6 of these implants. The nice thing about this procedure is that I'm able to visualize the urinary channel in real time, and so that I can be satisfied that I've left the patient with an open channel. All right, so this is actually a patient of mine. And if you can't see this, let me know. I'll take you through this video here. Let's go back here. All right, so again, passage of the camera into the bladder. This is the obstructive tissue, the prostate tissue that's squeezing the urinary channel. And this gives me an assessment of how large the prostate is and anticipate how many of these implants I need to put in. So this is the device that's going in. And as you can see, I'm lifting up that prostate. And as I lift that prostate, I'm satisfied with the positioning. I'm able to place the stitch and then tension the stitch and then apply the urethral end piece, helping that prostate to be lifted. And this process is repeated until the urinary channel is open. Again, we're treating the contralateral side now. And so I periodically take a look to see what tissue needs to be treated. And you can already start seeing that this tissue in the middle of the prostate has been treated quite nicely. And we need to treat the tissue that's obstructing close to where the ejaculatory duct is and where the bladder is. So we'll fast forward this a little bit because the process is the same when we're lifting up the prostate. Again, we're treating this. We're lifting up the prostate near the opening of the bladder. We're placing the suture and then the end piece here to keep that prostate lifted up. So we're going to take a look here. As you can see, there's the bladder. I've treated the tissue that was obstructing the opening of the bladder, the middle of the prostate. And I feel like there could be room for improvement over here towards the end of the prostate where there's residual tissue. And so we'll go ahead and place another 2 of these implants here. And let's take a look at the final picture here. This is the last the device that's going in.
I don't know about anyone else, but I'm not seeing a video.
Oh, okay. Well, I'm glad. Give me a second. That's what I was asking. Let me, sometimes the sharing process becomes an issue. Let's see if I can retry that here.
Yeah, I thought it was a problem on my end. What we were seeing was a still
I
of,
see.
yeah.
How about that? Are you guys able to see that?
Yes.
Okay, great. So I'll run through the animation or the actual procedure real quick here. Um, nope. Let me just reload that here. And the way the Zoom works is I had a suspicion this may be an issue because it it doesn't allow me to share more than one screen. So just give me 1 second here.
Everything else you shared came through fine.
Okay, I appreciate that feedback here. Okay, um, so you're able to see this now?
Yes.
Okay, great. All right, so let's go back here. All right, so here's the urinary channel, and you can see the obstructive tissue here that's squeezing the urinary channel. And so, again, it's not a separate tube, it's just part of that prostate. This is the UroLift the delivery device. So within here is the loaded suture material and the anchor stitch. So I've just fired that anchor tab that now is residing on the capsule or the outside of the prostate. I'm tensioning the suture, and then I'm putting the urethral end piece. You can see a little clip there that's holding that prostate open. And so that was patient's left side. I'm going to go ahead and treat the contralateral side on the right side. Similar way, pushing open that prostate, placing the suture into place, tensioning it, and then putting the urethral tab. And that, again, recoils and opens up that prostate tissue there. We'll fast forward a little bit, just kind of similar thing on the other parts of the prostate. I've lifted up the prostate tissue again. This is working close to the bladder or the opening of the bladder. I've treated the left side. Go ahead on the other side, lift up the prostate. And so, knowing where to put these suture is important. This is where, experience comes into play. And and so the constant reinspection, making sure that we're leaving an open channel. So again, opening of the bladder is treated nice and open. The most of the urinary channel remains open except for here, which is towards the end of the prostate. So this is where I've decided to place another two sutures here, another two of these UroLift implants. And again, lifting up that prostate on the left side. And you saw the first time I just wasn't happy the way it was lifting. I came back and kind of resituated that implant, and that takes care of that side. And we'll flip over to the other side, and we'll show you the final video here. Let's see. Okay, so now all the UroLift devices are in. This patient required 6 of them. This is the bladder, nice and open, unobstructed channel there. This is the middle part of the prostate, again, treated. We can see the pinching or the lifting of the prostate. And then as we go towards the end of that prostate. And so here I can look directly into the bladder. The irrigation I turn off, nothing's falling back in. And so this is what we're looking for when we treat the obstructed channel. You can see the before and after picture here. All right. Let's go back to that PowerPoint presentation. All right. So that is essentially what a UroLift procedure is. The other thing that I commonly do is called the green light laser vaporization procedure. Um, This is usually for men who may have larger prostates. There is a size limit to how effective the UroLift system can be. And so one of the things that we do in working up patients, we will do an ultrasound and get an assessment on the size of the prostate. So typically prostates up to about 80 grams respond really well to the UroLift procedure. I do have some patients who are hesitant in having anything permanently put in, even though it's completely safe. But they're against that, are looking for a way to actually remove the prostate tissue. As you can see that when I did the Urolift, I just reshaped the prostate. So it really ends up sometimes being a discussion. And you know, as a prostate, as a BPH kind of urologist, I really do pretty much every procedure that's out there, and we kind of discuss and custom fit to patients' expectations. Um, the green light laser has been out for over 2 decades. There are over 1 million men that have been treated through the green light laser system. Um, and it's a very effective long-term solution as well. So I'm sure you won't be able to see this screen, so let me stop this and I'll show you what the green light is. Now this procedure itself is also same-day procedure. Um, you come in under anesthesia, uh, have the procedure done and go home the same day. Um, and typically the procedure itself takes somewhere about 45 minutes to an hour, depending on the size of the prostate. Um, whereas obviously the Urolift is a much quicker procedure. So again, this is the urinary channel. Let's go back. I hate when this does this. Sorry, bear with me a second here. Go back here. Point shut down. So let's see. Here we are. Okay. Oh, that's not working. Let me see if I can go through the website here.
If you can't get it,
Yeah, I might give up on it, but it looks like it's more of a internet issue. Here we go. So I do have a YouTube channel where I have a bunch of my surgical videos as well.
uh,
Um, here we go. All right. Are you able to see the
no,
screen with the
all I'm seeing is this Google search screen here.
oh, okay. No, let's fix that. All right. You should be able to see that
Yep,
prostate now.
you got it.
All right. So again, taking a look inside, it's worthwhile noting that you see this bladder here. You see these are what diverticulum of the bladder look like. These are outpouches. This is secondary to not treating prostate enlargement. These bladder starts to undergo changes. So this patient actually had a very enlarged prostate. Um, the green light laser is a procedure that allows both vaporization or removal of the prostate tissue, and it kind of cauterizes at the same time. So that's really what's revolutionized the ability to treat prostate enlargement and resect it. The traditional way, the TURP procedure, often patients would have to spend at least overnight in the hospital uh, because the bleeding risk was elevated. So we used to have to monitor patients with irrigation. And so the green light laser has allowed that ability of same result within an outpatient fashion. Um, Also, with the green light procedure, we can do it in patients who are on blood thinners as well. It's demonstrated safety in that men who cannot stop their aspirin or Plavix, sometimes potent blood thinners. So we can do it in that situation as well. So as you see here, where we're taking that laser fiber to actually remove the tissue, um, it allows real-time treatment of prostate enlargement. Again, one of the other nice things why I like kind of both the UroLift and the laser procedure is that when I leave the operating room, I'm leaving a channel that's unobstructed and open. I'm not concerned about obstruction here. And so, essentially the take-home message here is a very effective system in men who are looking to actually remove prostate tissue and try to, you know, fix their urinary symptoms for a long period of time. So often, men who have had laser procedures continue to do well over the next 7 to 10 years without the need of any sort of other medications or surgery. So um, at the end of the procedure here, there's a lot of fluffy tissue. All this will slough off. That's a nice thing about a green light. The laser itself, the depth of penetration extends another 4 to 5 millimeters from where I resected. So that tissue will fall off. And you can see here what things look like before and after we're leaving the channel nice and open. The green light procedure tends to have a little bit longer recovery. Um, Most men need physical recovery about 5 to 7 days. Catheter has to be left in for at least 2 days. And then as far as the um, urinary symptoms to improve can take upwards of 2 weeks. And those urinary symptoms, as similar with the UroLift, frequency, urgency, and discomfort. Finally, I'll end at the aquablation therapy, which is another minimally invasive option. This is something that's been out since 2017. It's a very unique way of treating prostate enlargement. It is with the aid of robotic technology. So it helps to effectively treat prostate enlargement. As you saw the video on the green light, sometimes a surgeon's ability to completely treat the prostate can be limited by the visualization if there's bleeding or um, um, the way that the prostate is being resected makes it difficult to visualize. Sometimes you have to terminate the procedure earlier than wanted. The aquablation kind of eliminates that. Is actually the robot that's doing the resection part. Aquablation, as the name says, we're using water therapy, water treatment, to use water treatment to remove the prostate tissue. So unlike heat that's used in lasers, this this treatment is using water, regular water, room temperature water to remove the tissue. And I'll go over that in a second here. Um, just bear with me a second. I got just plug this laptop in. So the aquablation requires several steps. The first step is actually mapping out the prostate that we want to remove. And so as you see in this, basically this cartoon here, the outline of what we would like to remove. So again, when we're treating prostate enlargement, we're removing the tissue that's obstructing the urinary channel. And so we map out that prostate. The real time, we're able to identify the opening of the bladder. So it helps to prevent any injury to the opening of the bladder. And also the urinary sphincter, which if it gets damaged, can lead to urinary incontinence. We're able to identify and map that and protect that. So the mapping is the first part of it, where we're able to plan what needs to be treated. The second part of it is a very unique way, and it's actually a technology that the best I can put it is like a pressure washer, where you're using this high pressure wash to clean the driveway or the side of the house. In the same way, this high pressure directed beam removes the prostate tissue. Essentially, is kind of vaporizing it, and um, the robot part of it. So this is done robotically. The robot will follow the treatment plan that the surgeon has outlined. So it will remove the tissue that we have mapped out with exact precision. So it won't go past anything that we haven't mapped out. And also, we're monitoring this in real time. So we're watching the robot actually remove the tissue so that if we feel that maybe, it's getting too close to a certain part of the prostate, we can always reduce the strength of that water beam. This is what we're looking or striving to do is to remove that prostate tissue so that we're able to open that channel. Believe it or not, the whole process typically to treat the prostate takes somewhere about 8 to 10 minutes. Um, the the size of the prostate doesn't matter with this type of intervention, and so I've helped men who have had significant prostate enlargement where the only other option would be to go to the operating room and to remove the prostate tissue surgically. So this is really has no sort of size limit to how large the prostate can get. Now, the downside to this is that for most men, they have to spend overnight in the hospital, and the catheter similarly takes about 2 to 3 days to let things heal up. So the picture here you see on the left side, we use the ultrasound to map what we need treated, and then this instrument that goes in through the urethra is then using what we mapped out. This is outlined by the dots here. And so that's where the prostate used to sit. And you can see that the pressure jet is actually removing that prostate tissue. So it's a very highly effective way. There was an advancement to this technology this year with that artificial intelligence, that aspect of it. And so this is another treatment option that has demonstrated preservation of ejaculation in most men. Whereas the green light laser procedure, about 85% of men will experience retrograde ejaculation or the inability to ejaculate. The aquablation has demonstrated that the risk of ejaculation disturbance is about 15%. And there's really has been no increased risk of erectile dysfunction with aquablation. And that primarily is driven around the fact that, you're not using heat to treat the prostate. Whereas the other modalities that ablate the tissue will often use heat. And the depth of penetration with the laser, as I mentioned, will penetrate about 4 to 5 millimeters past where you want it. That doesn't happen with the aquablation. All right, so thanks for your patience through some of the technical difficulties. I hope you guys learned about prostate enlargement and some of the treatment options that are available. More than just a pill, there's many things that we have as urologists to effectively treat prostate enlargement. There really is no reason one should, struggle with urinary symptoms. And I think the take-home message is earlier intervention is key. Of course, you don't want to wait to a point where you can't urinate, although still, at least once a week, I get called by the emergency room that there's a patient there that cannot urinate. And so, again, if anybody's looking for a more in-depth conversation or consultation, my information is here. The office number is 845-437-5000, and our website here is www.premiermedicalhv.com.